Hello, everybody. Ignacio Mat Santos, and it's my pleasure to be the anchor person of this session. Also, I have the pleasure to have as discussants Marco De Carlo, Filippo Pensotti, Wojtek Wojciechowski, and Luis Nombela Franco. We are going to have certain objectives for your audience. I hope we will meet them. If we can go to the slides, please. So the principal learning points will be to understand this technology, understand the particular features of this technology, including the stability that it provides and the automatic release. And also we will have a glimpse to the new automatic and robotic assisted procedures that are starting to be developed worldwide. I think it's going to be a very interesting session. We are going to have fun. And with that, we are going to start with the live case. It's a recorded case. So we also have the pleasure to have as a spokesperson Ole Baker, who will be handling the discussion of the case. Thank you, Ole.
Yes, thank you.
Let's go to the case directly.
Hello, everybody. I am Ignacio Mat Santos from the University Clinic Hospital of Valladolid, and it's our pleasure to say this live in a box case with the VitaFlow Liberty device. I will give the word to the first operator, who is my senior fellow, Filippo Pensotti. Filippo, whenever you want.
Thank you so much, Nacho, for the kind introduction. First and foremost, I would like to introduce the rest of the team, which is composed to our nurse Alba, best of her class, Nerea, and Nieves as well. In our setting, we do not have an anesthesiologist because we are minimalistic in our TAVI practice. Today's case is about an 84-year-old woman, hypertension, type 2 diabetes mellitus, without any previous cardiovascular history, which has developed throughout the years severe aortic stenosis, high flow, high gradient aortic stenosis with 42 millimeters of mercury of mean gradient. In terms of EKG, she has sinus rhythm with normal PR and normal QRS. Nothing relevant in terms of lab tests, 14.1 of hemoglobin, 0.78 creatinine. And so we did perform, of course, an echocardiographic assessment to establish the severity of our aortic stenosis. As you can see, there is not much regurgitation associated with the stenosis, with, again, a mean gradient of 41 millimeters of mercury. After that, she underwent a CT scan in order to plan the procedure accurately. Mean perimeter 64.8 with a minimum annulus diameter of 16.6, maximum 23.6, meaning a small annulus which fits in a 24 size of VitaFlow Liberty valve. Sinuses of Valsalva are quite permissive, meaning especially the left one 28, the right one 26.2, and the non-coronary 26.1. Coronary height is permissive as well, 13.3 left main, 16 RCA. Calcification are non-negligible, I would say, especially on the free margin of the leaflets of non-coronary cusp and the left coronary cusp. We have our 3 cusp and a cusp overlap. Of course, we will implant our valve in a cusp overlap projection. And then in terms of femoral, the diameters and calibers are quite permissive without any major calcification in the femoral and external iliac part, but significant, at least parietal calcification of the common iliac arteries. So our procedural planning is a minimalistic TAV strategy with local anesthesia, radial access as secondary access, right femoral as the first one, and single operator release. Of course, as I said before, 64.8 millimeters of perimeter, which fits again in 24 millimeters VitaFlow Liberty TAVR. Thank you.
So thank you very much, Philip. So any comments on the strategy, guys? What do you think, Ole?
The strategy, or which, yeah, I mean, look, this is an 84-year-old lady, yes. So no doubt for me, TAVI, of course, she presents with a clear severe aortic stenosis, mean greater than above 40. Her anatomy, tricuspid, good, moderate to severely calcified. I think, in a way, she could be suitable for almost any prosthesis, except for she has a small annuli. Yeah, annulus. So she falls in a small annuli cohort. So I would indeed want to give her a prosthesis which gives good hemodynamics. Yes, that would be my preference. Then you come typically with the self-expanding platforms we have these days. And then I think it's preference of the operator as well. I mean, good access. So for access, you can go with any device as well. So that's how I look to this case. So not too many limitations, I think. Yeah. So I don't know what the others think. Marco, how do you look to this case?
I agree. It's a case that can be amenable to almost all technologies available. I saw that the aortic arch had a quite steep angle, and it was kind of a type 3 aortic arch. So maybe I'm curious to see how the valve behaves, because it's a longer, more rigid part than the capsule, so it will be interesting. And I would also like to ask if you plan to do pre-dilatation, because it's a severe stenosis, but not severe.
I send the question back to you. What would you do in the case?
I will pre-dilate.
You would pre-dilate?
I routinely pre-dilate.
I think using any self-expanding platform, I always pre-dilate, to be honest. I don't even question it anymore. I mean, I always go, even if it looks minimally calcified, I go for a pre-dil. I mean, you don't lose anything, you can only gain with it, I think. A better expansion of the valve from initial attempt, better anchoring with the final release. I think that's how I look to it, typically. I don't know. Yeah. Luis, you think the same, or you have other?
I totally agree that only in cases that we have severe aortic regurgitation, we don't pre-dilatate, but for all the self-expanding platforms, we always pre-dilatate. You probably with this valve, minimum diameter slightly higher than the minimum diameter will be enough.
You need less pronounced or aggressive, as they call it, pre-dilatation. It's not absolutely mandatory. This valve has a good radial force. We will talk about it later still, about the design of the valve. Has a really good radial force on the inflow part. So, but indeed.
But I agree that the expansion of the valve will be better if you pre-dilatate the valve. Yeah.
Okay, great. We go on with the procedure.
So we can see a nodule in the non-coronary sinus. We can see also where the valve is opening to cross, and the two-cast view. That is okay. We have also already checked the valve. That is already creamed by our nurse Nerea. Can you show the creamed valve, please?
Yeah.
That's it. We saw that there were no issues.
As you can see, Filippo here, who is my fellow, is doing the procedure as single operator, and I'm there as bailout.
As bailout.
We don't know yet if I will need to jump in or not.
A good safety net, huh?
You're the bailout doctor. Yeah.
You can feel the pressure of Ignacio behind you.
Yeah, I couldn't ask any better.
You can see also that the pressure is not brilliant. We have started noradrenaline from the beginning at low dose. And we said we don't have anesthesiologists usually in the lab unless it's a complex case that we anticipate higher risks.
And you also see it's very calcified leaflets.
Is very good.
This case.
Yeah,
Thank you.
It's not recorded.
A small calcified valve like this also pre-dilating avoids hypertension when you cross the valve with prosthesis.
Just to
it's actually a valve that has higher radial force than other self-expandable, so the discussion on predilation or no is worth. In general, I agree with you. We are better predilating, but if for any reason you don't want to, I think it's a good alternative.
Yeah. But with this amount of calcium I see on the fluoro, I would personally definitely predilate, I would say. Even with this device, I agree. It's a fantastic, nice radial force they have on the inflow part, which allows you a good expansion typically always, and then even a very high implant. But yeah.
So for this type of angulated aortic arc, would you consider using the other wire than the workhorse wire like Safari, something more stiff, less stiff? What's your approach?
Yeah, actually, if the arch, especially if the ascending aorta is very short, more than the angle, it might make sense. It's not the case here, so we didn't do it, but yeah, I think it can work. There is a lot of research on new stiffer wires that are dedicated for TAVI, because the alternative extra stiff is not a dedicated wire for TAVI, so we don't have a dedicated one, but if there is investment on that research, means that we really need it for some cases.
The ideal wire for me as a TAVI operator would be something really pretty stiff, Lunderquist style, all the way up to the mid of the ascending aorta, and then in the ventricle you can have something more like a safari style kind of. That would be, because you want some good rail, you know, you want some good stiffness, to be honest, to deliver your system.
So we are seeing the gradients now, which clearly confirm the severity. It's a huge gradient. We now are recording gradients before and after systematically. We stopped for some time doing that because we were on a hurry. So, but we are doing it again. We think it's very relevant for the outcomes. But I don't know if you are doing the same, guys. Are you recording systematically or not always?
Always. I mean, if there is no particular reason to skip the final crossing of the prosthesis after implantation, we routinely do it. It's important because it's difficult to estimate just visually if the prosthesis is under expanded. Sometimes when you have doubts, we do echo on the bedside before deciding whether to post-dilate or not.
For example,
we actually use the stress stiff. Filippo, you told me it was Safari. That's why.
Actually, I can do a recommendation here. I mean, I also, Lunderquist, there exists these days, it's called Lunderquist double curved extended.
Exactly.
And that's actually, it's a slightly different wire than this. It's of course the same wire, but the curl in the ventricle looks very Safari or Confida-like. So it's double curved, extended. It's pre-shaped with a double curve, so it feels even safer, because why are people more scared of using Lunderquist? Because the transition part between the radiopaque black part and the other more grayish part is relatively sharp. But if you have a double curved, it doesn't touch the ventricle really. So that could be a recommendation to use. Yeah.
Did you pre-shape the Lunderquist?
Yeah, I did pre-shape with the...
So it's not usually that way, but it's true that there are two curves. Yeah.
Oh yeah, a patient with a lot of...
Yeah, a lot of metal already inside.
So what was your approach here for access? So did you have a sheet and you went sheetless, or how did you go in?
We did have at the beginning of the procedure 6 French pre-close with the ProStyle, and then we did exchange for a 10 French in order to cross the valve. And afterwards we did put an 18 French introducer for making some room for the delivery catheter of the valve.
Yeah,
that's a dry seal, 18 French.
Yes.
So this device for the smaller sizes is 18 French. For the larger sizes is 19 French. And usually advancing in the femoral is good, but we like to prepare with a larger sheath than usual to make sure we don't have anything. But then we remove it and advance the delivery system. I don't know if that's your practice also, Luis.
Yeah, it's we usually put the sheath and then we remove it and introduce the valve. But yeah, to make it clear, no, it's equivalent to 18 French and equivalent to 19 French, no, the bigger valves. Yeah.
Explain that for the audience. What do you mean? It's like
that the outer diameter of the 21 and the 24 millimeters valve, it's equivalent to the outer diameter of a 18 French sheath, and for the 27 and the 30 valve is equivalent to 19 French. So you need to remove this sheath and then go sheathless with the integrated sheath that has the delivery system.
We are always lost in this French size translation from what the companies tell us and what we are using, but in this case it's actually 18 and 19, as you said. That's all. It's clear.
But to make it clear, it is possible to use this valve with the sheath.
Yeah, of course.
If the anatomy it's too difficult to go sheathless, but usually this dilator solves the problem, because it's very often the subcutaneous tissue that gives you the resistance. So it's
all the sheathless devices that are in the market, you can always use it through a sheath. The only issue is that the sheathless, the introducer, you have also to put inside the sheath, and that's why it gains. There is no device with a peel-away seatless system, which would be really nice if you are planning to do that. But for now, it does not exist.
So which balloon did you take here? Which size was it?
It was an 18.
18. So that's more matching the minimum diameter, yeah?
Yeah.
Yeah.
And it was non-compliant balloon or?
Was a non-compliant.
Non-compliant.
Dilation.
They can put the audio back on from the live case maybe, then we can hear the conversation in the lab. Yeah, you have your pacing here.
120. As you can see, we are pacing over the wire.
Yeah, you don't have perfect capture yet, but...
No, not yet.
Balón
Yeah,
arriba.
now it's coming.
Arriba.
Yeah.
Balón abajo. Balón down. Balón down. Pace off. Alright. Okay. That was very smooth.
I gave the orders to
this
do
one, it's
something
very
in the lab
important to do the empty
because
several
Filippo was
times
doing
to
everything. So.
close the introducer sheath properly.
But you see, we have recorded more than 100 cases now with this single operator strategy. And it's not just a single operator to show off that we are able to do just one person. I think it's a proof that the system is very stable, as we will see in a minute, and it can be done that way, and also the properties of the handle. This means that the nurse is helping, as you can see here. So it's not single operator, single physician. Hey, we have the audio back. I'm explaining something.
Yeah, we can have the audio. I don't know who's steering. We can have the audio on in the lab, please. Is there any technician? Yeah, technician is in the back. So please, can we have the audio on in the cath lab?
Very smoothly, no hurry. The dry seal introducer is being removed. Filippo is compressing.
So your dry seal sheet
Alba
came
will
out.
put the delivery system on the sheath. So first of all, Filippo is going to check that the tip of the delivery system goes in correctly in the common femoral artery, and immediately we will check that the Landerquist is in the right position in the LV. Once the sheath is inside the femoral, we focus on the ventricle. Remember, this is an extra stiff wire, so we have to keep an eye on that. So now you see the inline sheath. Alba, our nurse, will be holding the wire, and Filippo is going in the femoral. Good. I think we can go. Okay, let's have a look at the LV.
So I think we have to be fair and say you need normal good access, yes, for the valve. I mean, minimum 5.56 millimeter, preferably, yes. I think that's what I do, yes, in my patient selection. I think the valve itself is extremely versatile. You can treat from very small to very big, from minimal calcified to pure ER to extremely calcified. So there you're extremely versatile. On the access, that's maybe the only limitation I see for the valve is that those with bad or poor access is typically not my first choice, I would say. Yeah,
adverse access, we normally put our threshold in 6 millimeter for this device. And if it's too tortuous or too calcified, we don't use this device, or we use with a sheath if that's...
Yes.
Off button is what we can use there to activate the robotic release, the automatic release. If for any reason there is no battery or we cannot do the robotic release, which has never happened, we must keep it off, and then we use this torque that we can see at the end, and we could release manually also as usual. But here, if we do on, not yet, and then we can use these two buttons. The blue one is for the release, the white one is for recapturing. So whenever you want. Okay, let's cross the arch.
I think it was a good decision. You had the Lundquist here. It was well remarked from Marco. The arch was a little steeper, so I think you did a good job there to choose that Lundquist.
Okay, very smooth.
Yeah, I think it was Filippo who decided that. So
That was
thank
it.
you, Filippo.
You have a clever fellow. Yeah.
Thank you.
Okay.
It's interesting how it went nicely through the aortic arch without any friction. Probably the combination of a stiff wire with good manipulation of the delivery was
is that the valve is
key to
crimped inside the delivery system, but it's not at the tip of the delivery system. Okay, so we will go in the LVOT, and the prosthesis itself has to be positioned more or less at mid-pigtail height, if the pigtail is correctly positioned in the non-coronary.
There is no commissural alignment so
Because
far.
that way, when we open, the valve will dive in to the intended position.
So the valve is always crimped in the same orientation, but they have not developed a specific implanting orienting position. The problem is that the buttons are on the upper part of the delivery system, so if the position will be 90 degrees, that can be an issue for the deploy, but still working on that.
This is why probably you are
So now to make it clear for everybody in the audience, so this is the cusp overlap view you are in. You can see it, it's caudal, ariocaudal, and it's also the ascending and descending aorta are overlapping. You can only have that when you look from an ariocaudal, from the so-called cusp overlap.
There was an issue here. It was occupying all the non-coronary sinus, so it was tough to put the pigtail down. So we lost that reference. We have to keep that in mind during the deployment.
But I think this position is a good position to start, no? Because when you start pushing the blue button, then the valve usually tends to dive a little bit. So to start a little bit higher than the bottom of the non-coronary cusp, I think is usually what we do.
And now I think we should keep an eye also on, of course, the fluoro, but also on the left bottom on the camera. And that's the ease of use, yes? Maybe Filippo, you can comment on that. What you're doing is, what are you doing here?
Yeah, there are two buttons, the posterior one, which is basically an on-off button, and then the anterior one, which is a release recapture button. And then you have, when you are in the correct position to do the implant, you have to start pushing the release button while maintaining a slight push on the delivery catheter in an intermittent fashion, meaning zzz, 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 and then there is, you can recapture the valve up to 75% of the release, which is the no recapture point. So we are opening right now the valve up to the no recapture point, checking the valve. The position is good. All right, let's push again the release button and fully release the valve.
So in fact, with your left hand, you're doing the in and out, deeper or higher, and with your right hand, is just you push on a knob, the motorized handle, to release. That's basically it. So it's extremely simple.
Here you're aiming at 1 millimeter depth of implantation, which is very difficult to keep with other platforms. So it's really important that you can predict where the valve will deploy fully once you have released it.
Yeah, we can discuss it later. I mean, let's focus now here on, but indeed, if I may, it's very stable. It's thanks to the frame of the valve, how it deploys. It's not too tapered, and also the catheter helps in having stable deployment. Yeah.
The lack of tapering is crucial also for the coronaries, I think, and the stability, it provides huge stability. And with the left hand, as you said, Filippo was handling the delivery, and the left is for the bottom, but also for the wire, so you can be playing. The deployment is quite quick. We are seeing it now, so there is stability all along the deployment, but there is no stopping point, so we have to stop when the valve is functioning. We should not release completely.
Are you usually pacing when doing?
Yeah. It depends on the pressure the patient has. I think here we connected at 100, and the patient was a bit tachycardic, so it didn't pace much. So we are going to stop here. See this image, and what do we do here, guys?
We do another projection to see what's the depth in the left lateral, because sometimes it's really higher than we think. Also, there is some parallax.
Yeah.
So I would use another projection.
So correct the parallax in another projection. Something else we need to know here before final release. what would you change? What are your opinions? You cannot say it, Filippo, because you did the case. So. Regarding the wire, the delivery system before final release?
Yeah, you have to check that. Also, I check that if the delivery system is centralized in the aorta, but it's better to go to an LAO projection to check this, because in this view it can be confusion. And maybe the wire, I don't know if you have a lot of pushing tension of the wire, because it seems that it's a little bit on the apex, so maybe releasing also the tension if you decide to continue with to release the valve. Yeah.
Okay, great.
A question from the audience is: are you not afraid to scratch the arch with the capsule and the clear gap at the cone?
Looks good.
No more than with other self-expandable devices.
But we have to remove all the tensions towards the aorta.
I think it was indeed a good choice to use Lundquist in this particular case, but no, indeed, I also don't have any further. It feels actually the surface feels extremely smooth, yes, with on the device.
The parallax was corrected, and now I think Filippo is removing the wire bit, as Luis mentioned. And just pushing gently the delivery system to get closer to the outer curve.
It's a matter of feeling the pushing, just that.
Look,
Okay, so
I mean, now I didn't know, I didn't do the case myself, but I would even in this particular case, in this particular depth, working with this device, I would have kept the wire there if there wouldn't be too excessive push on it, because I mean, this valve is sitting relatively at 2 to 3, good strong device, pretty oversized for this anatomy. I would never fear for a pop-up in this device, so I would even have kept probably my wire, I think. But okay, I mean, I agree. If you're scary high, you have to pull it back.
Hemodynamics are good. I think you can pull back the delivery system. Sure. Si quieres sujetar el introductor.
Oh yeah.
Of course, you have to check that the 2 tabs are free before you retrieve the system.
Exactly. So one thing we do, so the 2 tabs were released. We centralized the wire, removed the nose cone, and now one thing that I like about this delivery system, the recapture of the delivery system is also automatic. So you really don't need to do fluoro. You can recapture with no, because it's advancing, so the wire is not gonna went out of the ventricle. We did it live just to show how it works, but it's something that we are doing off fluoro.
Extra fluoroscopy. We don't want to radiate as more than necessary. But here, just to show you, we are doing under fluoro, and you see the nose cone coming. So the delivery catheter is going up, so in this step the wire will never go out.
But what it shows also at the final release, you didn't see any movement of the valve, yes? That's also real typical. I mean, this valve never really, in my hands, goes down or up. It stays there. And that's because of the radial forces of this valve. You see that the nitinol network is also the most dense on the inflow, and it's much lighter on the outflow. That's actually a smart design, I think, because they have the most higher radial force on the inflow, where you anchor, and then you don't want a lot of metal in the outflow for your coronary access. Yes? So in that sense, it's a smart design.
I think the key is the initial good positioning. And from there, you are safe all along the procedure, and also hemodynamics are good, so yeah, it's...
No bleeding? Perfect. So now we remove the delivery system and we advance the...
Keep in these small anatomies, well, probably the valve is not going to affect, but do you keep the pigtail always in these small anatomies in place?
Yeah, we're trying to keep it in place till the end of the implant, yeah. And removing it with a standard J wire.
There's a question from the audience. Yes, indeed, that's a mistake from us. Is the valve intra or supraannular leaflet position? We didn't explain that too good. So somebody wants to talk about that?
I think you might show later some of the features.
But you can already give the answer.
Yes. Yeah, it's a I can, yeah? It's a supraannular device, and this is why we chose in this particular anatomy. I think small anatomies might benefit from supraannular devices in terms of hemodynamic. indeed, we will check at the end of the procedure, and it will look good.
So indeed, it is supra and a leaflet position, but the skirt up to the bottom of from the inflow to the bottom of the cusp, so that skirt there is only 10 to 11 millimeter. Whereas if you compare them, for example, for Evolut, it's 13 millimeters. So it's just 3 millimeters shorter, which is a great thing in a way, because you want the benefits of a hemodynamic superior valve, which they have, but you don't want the leaflets too high neither.
Another important issue when you are thinking of potential TAVI in the future is that they already have more than 9 years of follow-up of patients implanted in China. So the hemodynamics appear very stable throughout 9 years of follow-up. So this is also important because, of course, in a small annulus like this, you might be scared of a second intervention if the valve life is short. So far we have reassuring data about the durability of these prostheses.
So for now, in this case, we see the hemodynamics were excellent.
Yeah.
We see that the QRS might be a little bit wider, but no pacemaker. And there is only the final angio to show that we are going to show in a minute.
So this could be
I think I will advance just a tiny little bit.
Second operator, but there were no cases where the issue was related to the valve, meaning valve embolization or annular rupture to a annular leak. Patent coronaries, well expanded, no gradient. Now yes, we are ready to close.
It's very nice.
Already. Okay,
So what about the final depth, guys?
It's excellent. I mean, you have a 2 millimeter depth, you have no leak, and that's also what you typically see. As if you implant the valve correctly in a correct depth, you never have any PVL, and also really no. I mean, like even not mild typically. So it's repetitively executable, I would say. You even by chance had commissural alignment.
Yeah.
So your fellow is really good.
So in your experience, I had only once to post-dilate this valve, but usually it has enough radial strength, so after pre-dilation you don't need
a lot of radial. I mean, I use this valve also a lot in bicuspids, excessively calcified bicuspids, and then sometimes I still post-dilate, to be honest, but yeah.
Yeah, probably that's a setting with large experience, because as the companies from China, they did a lot of bicuspid cases, and in bicuspid, very often the calcium and the eccentricity is an issue for self-expandable, so we tend to go more with balloon expandable, but balloon expandable can have risk in eccentric calcium in some settings, and I think this valve plays a particularly interesting role in these bicuspid patients. So we check by echo the femoral. I skipped that part because we are a little bit late.
But let's address a couple of questions here. There comes in some questions from the audience. Should we do that? We have the time also.
Yeah.
Here, first, somebody who challenges you on the single operator, he says it's not truly single operator, you need an extra pair of hands. What do you say?
Well, in just a small passage of the procedure, of course, yes.
Yeah.
But the implant is made entirely by a single operator, and so.
So I think it's worth mentioning, because it's not for the sake of showing that you can do like a one-person procedure, but I think I wanted to ask both of you if it makes training of the fellows easier, because as a fellow probably you feel more independent, you still have your supervisor available in case, but if he's not with you at the table, maybe the training would be more efficient. How do you feel about it?
So and so, it depends. I mean, I learned TAVI the old way with the senior staff just beside me, and I found at the same time comfortable and stimulating, so I didn't find any particular difference doing it all alone with Ignacio behind me. But could be for some people, yeah.
For me, the key, sorry, Luis. For me, the key is not the single operator, but the ability to need less human resources. You might have the nurse next to you, or you might have a senior, but it gives you, as first operator, the independence to decide where you release, how quickly, how slow, and that's differential. And it's thanks to the stability of the valve.
I think that we don't have, currently at least in my setting, we don't have shortage of operators. We have plenty of people who want to do TAVIs, particularly surgeons now. Yeah, but I think that the coordination that you need between the first operator and second operator, particularly when the self-expanding valve is a little bit slippery and tends to go up and down, and if you're not well coordinated with the second operator, you may expect the second operator to push on the wire, it doesn't push, and then you pull back and it moves not in a very coordinated way. So having a more stable system and potentially a system that works with a single operator is an advantage. And if I may guess, in 10 years' time, I think that most self-expanding valves will have a motorized pullback.
Yeah. Would you please explain how you do commissural alignment? Well, there's no way to do it, but maybe can we get the image maybe on the last angio there? In the cusp overlap, we can explain how we can see it's commissurally aligned. That we can at least explain. Yeah, when the valve is totally implanted, where the delivery system is maybe also out of the way, we can actually see the taps, the commissural posts. Yes, if you go a little further. Yes, here. Like, yeah.
We can see one tap here, and the other is here, right behind the pigtail.
Well, it's easier to look. Scroll a bit further if we can see the commissural posts, maybe. Yes, there. Leave it. Yeah. Oh, you had it? Yes. Leave it there. On this picture. Look, we can make. I think we can draw on this, isn't it? Yeah. Let's try, at least. Oh. Yeah. Can I make a drawing?
So what we are seeing here is the tab here, and the other one to the other side.
Yes.
In this cusp overlap.
So look, for those. So to make it very easy, so you first of all, even without seeing the projections of the numbers like REO, LEO, caudal cranial. Oh yeah, now it goes away. But anyway, you saw, I see immediately this is an REO caudal. Yes, why? Because the ascending and descending, it's logical if you take it from there. Like if you're, I can draw here for example, if you have, this is REO, yes, REO, LEO, cranial, caudal. We have then the S-curve, of course. Well, everything you work in the LAO space here, you will see the arch typically open. Like the arch will be, you will see an open aortic arch. Yes, that if you see this, quite a big distance between your LV wire, your wire in ascending and descending, you know you have a projection in the LAO field. Now you saw here at the end, the descending and ascending, saw like, it's almost like, it's difficult to draw probably, but yeah, something like this, yeah? Like I have to work here three-dimensional, but a bit like this. Yes, overlapping arch and aorta. Yeah, ascending and descending aorta. The wire was going a little bit like that. Yeah, then you know you're working in an REO projection. So okay, then we have certitude. We're working in an REO. What Ignacio showed there was actually a valve implanted in this way. So this was in fact, the cusp overlap, so that means this is the non-coronary cusp, this is the right coronary cusp, and the left coronary cusp. This is the cusp overlap view in the REO caudal. If you think, how are the commissures in this anatomy? Well, here are two cusps. So there is a commissure, yes, in between these two cusps. So there's one commissure pointing to there, yes? And then there's a commissure 120 degrees between this leaflet, the non-coronary cusp, and the right coronary cusp that's pointing to there, and another commissure also pointing to there. Everybody agrees? Yes? Well, if you have that, two commissures there, one commissure, that's exactly also, if we can get the image from the fluoro back on, you see there, you can maybe show it with the hand. Yes, you had it actually there.
Yeah, but that was the three cusp, and this is the two cusp.
Yeah.
Yeah, and we can see the commissures.
But if you go a bit further, they can see it clearly, I think. Yeah, even there a bit with Cine. Yes, there. That's good.
Here we see one tab, and here we see two.
Yes, you see the valve implanted this way. Yes, you see it like this, simplified. Yes, here are the arches, of course. And then you see one commissural post there, another commissural post there. Yes, you see that there, and then one commissural post isolated there. So these commissural posts are identifying the commissures. So exactly that's what they have. They have one commissure to there, the other two are pointing to there. So that shows that they have indeed commissural alignment. Yes, so that's the matching the anatomy of the patient.
One here, one here,
Yeah.
one here. Okay.
Yes. So that's what we discussed, not yet a full control over it. I also didn't notice, I mean, I didn't keep an eye on it to say if in 80% you always come in this or that. I don't know, I cannot say that, honestly. I don't know the percentage you always come with commissural alignment or not. Depends from your patient's anatomy, I guess. Then there was another, when do you need to post-dilate? I think that's patient preference, operator preference, sorry, but typically you post-dilate for bad hemodynamics or PVL.
Bad hemodynamics and PVL, and since accurate experience, right now we are looking more at valve expansion than before.
Yeah, in bicuspid cases, we also check the degree of expansion into views. That's very important. I think it's important in all the anatomies, not only in bicuspid.
Yes.
And that could be a reason, but here it was not necessary. And I think in the manuscript we are preparing with the single operator experience, the rate was very low.
Yeah, the post-dilation was around 10 to 15%.
Yeah. And then another question, we've had issues, somebody writes, of too much movement of the valve in valve scenarios with significant leak, significant AR. So indeed, I can comment on that, but maybe some of you want to comment on that, what to do against that. If you do a valve, and especially then within a self-expanding technology, what's the trick? What do you do? Do you do something special?
You mean for the movement? We usually pace a little bit, and when it contacts, then you can stop. And when you are assessing the depth of the device, you can you stop pacing there. But
well, indeed. Look, I mean, if you have a severe AR, the beat of flow that goes over the aortic valve always is higher. Yes, so it's logical that in a way you can have more movement of the valve. So what I do with any self-expanding platform, regardless of whether it is this one or another one, if you go across, then and if you already see it rocking in that ring, the surgical ring there, then you can already start immediately giving. I give 120 pacing as baseline. Typically, a patient keeps that very stable. And I honestly, if I do a valve, I always, if it's balloon expandable for sure, but if only for my self-expanding device, I pace always 180.
It's a good trick. I think it's necessary, especially in the regurgitation failing mode cases.
Even then, but even in stenosis, because your prosthesis typically has quicker contact with your valve. So I always give with this valve. Also, by the way, what my implantation strategy is, I don't know. I didn't keep an eye on how much pacing you gave. How much pacing?
We did 130 pacing, but just for a few moments.
Yeah.
Most of the deployment was made without
I'm even more
pacing.
aggressive with my pacing strategy. I typically go, when the valve is in the catheter, you don't give any pacing yet. Then when you see the valve just peeping a little bit out, then I start my pacing 120. I do it because my valve stays a bit more stable. If I give contrast, the contrast keeps on swirling a little bit longer around. It's not with one single heartbeat completely gone. And then when my valve is around 20, then you do your whole focus on depth. You want to be as precise as possible to your 1 millimeter or so, or 1 or 2 millimeter with this valve. And then when it's 20 to 30%, then you know if you go a bit further, the valve really is gone, going open. So then I go typically with 160 pacing even, and that's even 4 or 5 seconds only. All my cases are in local anesthesia. I never really find the patient losing consciousness on that. It's just that short episode. Then I'd like to pace quite high in rate, 160, do the opening, 4 or 5 seconds to 80% of the valve, and then I go down to pacing in 180, stop the pacing, for example. That's what I do typically.
I do the same. Just the threshold for pacing is based on the blood pressure of the patient. If the blood pressure is below 60, you can reasonably expect no movement. So we can start at 120 up to 180 according to the level of blood pressure. If systolic remains low, you can.
So I think we saw the case first, and we didn't stop properly in all the specificities of this device. But now we have the privilege to have Ole explaining all these features of the device to us. Please, Ole.
Yes. No, thank you, Ignacio. So this valve has a couple of a unique aspects as we already discussed before. So what I like a lot about this design is, first of all, I told you already, the more dense nitinol network and the inflow, more open on the outflow, so that makes that it has a good radial force on the inflow and is kind of softer on the outflow. Also, what is smart about this design, I would say, is the tapering of the stent frame. So it's a fixed tapering. I think I show it on the next slide. Maybe not. But then, so there's some prostheses, self-expanding prostheses, have a very tubular stent frame. The problem there sometimes is if you want, you cannot really aim extremely high with these prostheses, because then if there's a lot of under expansion on the inflow, it sits almost ready as a champagne cork to pop up. Some prostheses, like an Evolut 34, for example, has a very outspoken waist. Well, that makes it very hard to control this valve and to avoid kind of a pop down into the LVOT with the final release. So you have to find that sweet spot, not too tubular, not too tapered. And I think in a way, the VitaFlow is going very close to that sweet spot, what you want, of some tapering, avoiding pop-up, but also not too much tapering where it sucks itself into the LVOT. So here, the cell density I already talked about. So you have more cell density on the inflow. That's actually also where you want to have the most radial force, because there, that's the function of the valve. It has to push the calcified leaflets on the side. But you do not want necessarily a very dense nitinol network on the outflow where you want to preserve your coronary access. Yeah, so that's good about it. Implantation depth, yeah, I think everybody knows that implantation depth is a predictor of conduction disorders and pacemaker. What it allows, this high radial force on the inflow, if you have to explain this to engineers, typically they don't understand you initially. Because if an engineer, he thinks like, yeah, but wait a minute, you want to avoid pacemaker, probably you don't want too much radial force on the inflow. And then you have to explain like, no, me as an operator, I want a lot of radial force on the inflow, because if I have that, I can repetitively and reliably implant very high. I don't have to be scared for a pop-up. So it's counterintuitive for an engineer, but as an operator, we know, and this is what my feeling is with this device, I like the radial force in that inflow part, because I'm never scared of releasing this valve, even not at 0 or 1 millimeter, it will always remain in place. And that's a nice kind of feeling. So the official recommendation, sorry, I go back, is 0 to 4 millimeter, but it's very rare, I would say, that I release this valve at 4 millimeter. I mean, it's typically around 1 or 2. I typically don't go for 0, but 1 or 2 millimeter, it's doable, and you can do it pretty precise as well. So here you see, even this is an extreme case, probably must have been also some kind of bicuspid case, because with some raphe here, maybe a type 1 right non-fusion or something with a calcified raphe between the right and the non. I don't know which case it is. It's not mine case, but these are definitely some weird looking cases, more bicuspid cases, I think. But it shows you again that you can come away with very high, nice implants with good sealing and no PVL. Stable anchoring adds to predictable redeployment. That's also true in a way that if you do, that's also helping there with the motorized handle, I would say. If you have to reposition, that motorized handle helps also really a lot to do that pretty stable. You control it all yourself, your depth and your motorized handle. So that motorized handle in the beginning, I thought it was more like a gadget, probably not necessary, but I start to see the benefits of it. Large cells, indeed, at the outflow, they preserve more the coronary access, and that's what we want. I also told you already earlier that the skirt on the inflow is slightly lower than, for example, for an Evolut. You want to have that supraannular hemodynamic benefit, but don't want to have a too high skirt. I think they're also relatively close to the sweet spot there, what you want. So this is kind of what I wanted to show about this particular prosthesis. Yes?
Okay, great. Thank you, Ole. Maybe, Carlo, you can comment something on bicuspid patients. I know you have a good experience, and what are your thoughts?
Well, we've been doing bicuspid patient mostly with self-expanding prosthesis, and so lately we also did a few patients with bicuspid anatomy with VitaFlow, and actually the experience was very favorable because the prosthesis is absolutely stable, and with an adequate pre-dilatation. Sometimes we use, as Ole suggests, two sequential inflations of the balloon for the pre-dilatation. And then in almost all our bicuspid patients, we didn't even need a post-dilatation, which is a quite rare occurrence if you think of other self-expanding prostheses. So yeah, I'm a little bit scared when there is a RAFI to use a balloon expandable valve. This is really operator preference, but if you have to choose a self-expanding because you're scared of potential interference with the aortic root structures and wall, then choosing the self-expanding prosthesis with the highest radial force makes a lot of sense. And again, the experience was really, really impressive in terms of adequate hemodynamics even without post-dilatation.
There's a question here also. What are you trying to see in an LAO view? Why do you go there? Like somebody asks.
Well, I mean, we do this in all self-expanding valves, and you start in the cast overlap, you adjust the depth, and then you want to go to the LAO to see if you are the height of the left coronary sinus, and also how is your delivery system, if it's centralized or if it's in the outer curve of the aorta or in the inner. So if you are in the inner, you have too many tension, pullback tension, and if you are in the outer, you are pushing a lot the delivery system, so you need to release also the tension because you don't want to go to dive the valve. So,
yeah, that's a good point. I think these are both two good points. I can make it. I have limited time, I know, but I want to try to give you this drawing still. Look, when you cross the arch with any TAVI platform, your wire typically sits, if it's a normal anatomy, your wire sits in this commissure between the right and the non. Yes, on the outer curvature. Yes. So every prosthesis, if you come with let's talk now about the VitaFlows or any other one, it sits also there. Yes. You work from an REO view. Yes, you work from an REO view. This is FAS. Yes, this is REO. This is LAO. Yes, I'm the patient in the scanner. Yes, this is REO. That's LAO. Yes. So if you look from REO, this is indeed the right-left cusp overlap view, and you have your pigtail in the non. That's what you see here. This is the right-left cusp overlap view. You have the pigtail in the non, and the two others are overlapped there. Yes, your system falls into that commissure there. You do all what you can to be as precise as possible here, to be at, for example, 2 millimeter. Yes, and so then you do your expansion. If you're in that commissure between the non and the right, you do all your efforts to be as precise as possible at 2 millimeter in relation to the non. You do, in a way, automatically the same effort for the right. Yes, because you're starting that commissure between the two. But then your valve systematically expands. It becomes bigger and bigger. You expand actually towards the left. Yes, the valve is expanding from the non-right commissure towards the left. So when you have that valve hanging on 80%, you're pretty sure about your depth 2 millimeter in relation to the non/right. You still want to find a view where you're really bloody sure that you don't miss the depth on the left side. So what is the best view to do that? Well, then you swing over to on the S curve, you swing over from this quadrant to some LAO view. Yeah, you can do it here, but then typically you go a bit lower to take the parallax out of your valve, and then you end up in this situation, and then you have your valve open, yes, and then this is the perfect. You see your left main also here. So this is the overlap. They're typically not very overlapped because you corrected for the parallax, but anyway, you isolate the hinge point of the left coronary cusp. And then you give contrast and you judge your depth here in relation to your left. So then you're pretty sure about your non/right because of your REO view. Yes, in my REO view, I typically only check for my depth from at this side, and then you swing over to the LAO view, and that's very useful. Gives you very useful information that you don't miss the left coronary cusp hinge point. Yes, that's the rationale why you start out in an REO and you go over to the LAO to check your depth in the left, and if that all looks good, you go for a slow final deployment. Yes, that was the kind of explanation.
Thank you, Ole. That was super clear. I think it was a good point for this device and for many others. And now we are going to have a glimpse to the future through Filippo Pensotti, the next gen of interventional cardiologists. Filippo, when you want.
Thank you, Nacho. So how single operator technique and robotic assisted technology could change our TAVI practice? Well, the question should be, what are the main challenges of TAVI in 2025? Well, besides of the procedural issues that we already discussed throughout the Congress, one of the most important thing is logistic, meaning that as TAVI demands grows annually worldwide, unfortunately, so does the waiting time for the procedure, and therefore has been associated with an increased risk of heart failure hospitalization and cardiovascular death. Also, from the financial point of view, the delayed TAVR has been associated with an increased cost of the patient for the healthcare system, and therefore represent an increased economical burden for the country. On the other side, as you can see in this survey published from the European Society of Cardiology, the number of procedures per million people is somehow linked to the economical income of the country. And therefore we have a double challenge. In a high-income country, facing the increased waiting time for the procedure, and in the low-income country, the adoption of the procedure, which is, we are not still there. So how can robotic could help in achieving, in facing these challenges? Well, let's take a step behind. Since 20 years, we tried to develop some sort of robotic-assisted PCI, but there were important limitations that has never been solved, such as the longer procedure time, the lack of tactile feedback for the operator, and of course, the increased cost, and more importantly, the impossibility to perform the procedure within complex coronary anatomies. And therefore, the characteristic of the robotic-assisted technology and the autonomy of the machine themselves have been defined by this review published on neurointervention previously this year, in which they range the anatomy of the robot from level 0, meaning no autonomy, and so a robotic-assisted procedure, to level 4 and 5, meaning high and full autonomy. Right now, where are we? Well, somewhere between level 0 and level 1, meaning that the robot is capable of achieving just simple tasks while interacting with the operator when it faces some difficulties. And then, although the possibility to perform TAVI comfortably sitting outside the cath lab is an attractive option, we have to face the reality. Where are we? Well, this year has been published last month a paper about this experiment that was carried out in France in the last couple of years, in which they developed a Phantom with the robotic-assisted technology maneuvered through a joypad. And firstly, they did try to do an aortic valvuloplasty in the Phantom in a robotic-assisted fashion, and was safe, was possible. Then they move on. They implant a balloon expandable valve inside the Phantom, and again, was safe, was possible, and they move on. Last year, they did an implant, as you can see on the right side of the slide, in a pig with a balloon expandable valve, with a robotic-assisted technology standing in a room aside of the cath lab, and again, was possible, was safe, and was successful. And then they moved to the main task of the paper, which was assessing the precision of the robotic-assisted technology compared with the fully robotic procedure, compared with the manual guidance. And they found out that 4 different operators try to perform those tasks, and they found out that despite the different operators, the fully robotic procedure was way more precise and way more accurate in terms of implant depth compared with robotic-assisted technology and compared with fully manual deployment. And therefore, one can speculate that could be more successful, the procedure. In the meantime, in China, previously this year, they were able to perform the first ever in human fully robotic-assisted TAVR procedure with their React tactile TAVR system, which was engaged manually to the delivery catheter of their self-expanding platform, and then was maneuvered outside the cath lab with a joypad, with a console, and they were able to achieve a successful procedure also at follow-up, as you can see on the right side of the slide. And therefore, we have to keep in mind that logistics and economics are still one of the most important issues in TAVI in 2025. the ability of performing TAVR with the single operator or robotic assisted technology could switch a bit the procedure toward the more, let's say, PCI-like procedure. But in order to be globally adopted, these technologies have to learn from the pitfalls and the failures of the past, meaning the robotic PCI. Thank you.
Thank you, Filippo. I think we came with that. Thank you for the great talk. I think with that we also came to this end of this session. I think in this session we wanted to show you how new devices can potentially bring us to a further breakthrough, I would say, in optimizing these procedures. This valve, in the case as you showed, has a great performance. But even I have to say, as your last talk was, I think in the beginning I was also a little bit skeptical about the motorized handle. I was like, yeah, do we really need it? But actually having it, you start to love it and you see the benefits of it. And I think maybe this all sounds very futuristic, but that's the same with when they were having horses and charge still, went to cars, and then they were talking about self-driving cars. And look, everybody thought like, yeah, that sounds crazy. Why do we need it? And is it going to be safe? Now these days in San Francisco, and so they're driving self-driving cars. So I think this is only the beginning of structural heart disease interventions. Definitely even also for more complex cases like microtricuspid multimodality, imaging, integrations, and so I think we're only at the beginning of all this more kind of robotic or robotic assisted or AI-driven structural heart disease interventions or care. So with that, I want to complete this, not procedure, but this session. I want to thank all the panelists and you as an audience to come to this session. So thank you.
Thank you.